Thank you for having me here. It's always a privilege and an honor to be part of this group and this symposium. So I'm going to talk to you about newborn screening, and I'm going to start with the definition of newborn screening. This is one of the definitions that I like the most because it summarizes everything that newborn screening is. So newborn screening is a public health activity aimed at the early identification of conditions for which timely intervention can lead to the elimination or reduction of mortality, morbidity, and disability associated with this condition. So in a nutshell, what it means is you need to have a way to identify this condition early, so you need to have a marker that's present and allows identification before the symptoms are evident. You need to have an intervention, so you need to have a way to act for this patient. And not only you need to have an intervention, the intervention has to be effective. So that's what newborn screening really is for. So let's talk now about cerebral creatine deficiency syndrome. I'm just going to give you a very brief background. I think everybody here is an expert, more than I am. So these syndromes are characterized by intellectual disability, autistic-like behavior, seizure, and cognitive delays. Can also present with moderate intellectual disability, attention deficit disorder, hyperactivity, and language disorder. They are caused by defect in either creatine synthesis or in the transport of creatine. So let's look at the creatine system. So creatine, the synthesis of creatine starts from arginine and glycine. And is there a pointer? No. It starts from arginine and glycine, and through the action of the first enzyme involved in this pathway, arginine-glycine amidinotransferase, these are converted in ornithine and guanidinoacetate. The second step is the conversion of guanidinoacetate, so methylation of guanidinoacetate to creatine, through the enzyme guanidinoacetate methyltransferase. Once creatine is synthesized, then the creatine transporter can deliver creatine to all the organs and tissue that need creatine. Creatine is also taken up from the diet. It's not only the pool of creatine derives from both the diet and endogenous synthesis. So let's see what happens when something in this system goes wrong. So if we have an impairment in the first step, so if the enzyme arginine-glycine amidinotransferase does not work properly, then guanidinoacetate cannot be synthesized. So guanidinoacetate will be low, and at the same time, because guanidinoacetate is the direct precursor of creatine, creatine is going to be low. Second step in the synthesis is catalyzed by the enzyme guanidinoacetate methyltransferase, or GAMT. If this enzyme does not work, then guanidinoacetate will accumulate. And this is what is going to cause additional problems. And at the same time, creatine is going to be low. And then finally, if we have an impairment in the transporter, in the creatine transporter, even though creatine can be synthesized, it cannot be delivered to the organs where it needs to be delivered. So there are overlapping symptoms among the three conditions. But there are also some that are specific, more specific to one condition or the other. So all of the three syndrome, they share the same presentation with intellectual disability, speech delay, behavioral problem. Seizures are not always present in patients with AGA deficiency, but in GAMT deficiency and CTD, they are observed. Movement disorders are more common in GAMT deficiency, myopathy in AGA deficiency, basal ganglia changes in GAMT, and then gastrointestinal symptoms, like failure to thrive, vomiting, reflux. These are more common in patients with CTD. How are they diagnosed? One thing that they all have in common is low creatine in the brain. So by MR spectroscopy, you can see that the peak of creatine is either missing or reduced. On this MR spectroscopy drawing result here, on your left, there is, it's the one from a patient with creatine deficiency, and next to it is an unaffected control. You can see that there are three major peaks that are revealed by this examination, by this test, and they are choline, creatine, and N-acetyl aspartate. In patients with creatine deficiency, choline and N-acetyl aspartate are present, but the creatine peak is missing. So this is common to all three conditions. Then we have also a way to diagnose them biochemically. I'm a biochemical geneticist, so I love the biochemical test, and I am getting very excited usually when I see some unusual results. So we measure them in plasma and in urine. In patients with AGA deficiency, if you remember, first step in the synthesis, guanidino acetate is not synthesized properly, and creatine is not synthesized. So in plasma, you can see guanidino acetate is going to be very low, creatine is going to be very low. And this is true even in the urine. In my experience, we can see how low is guanidino acetate. It can be close to zero, so really very low. GAMT deficiency, second step, guanidino acetate cannot be converted to creatine. Guanidino acetate goes up and creatine is low. So this is true, especially in plasma. We are going to see the example of the newborn with a urine guanidino acetate that was within the normal range. So very reliable, especially in plasma. In creatine, with creatine transporter deficiency, creatine and guanidino acetate are going to be within the normal range. The synthesis is not impaired. However, when we look at the urine and we look at the ratio creatine over creatinine, this is very high. Why is that? Because the transporter is expressed even in the kidney, and if it doesn't work, it's not allowing creatine to be reabsorbed. And so creatine is going to be lost in the urine, and relatively to creatinine is going to be much higher than expected. So this is something that it's very sensitive method to diagnose the biochemically CTD in urine. Then the diagnosis is confirmed by DNA testing, and enzyme and transporter assays are not readily available yet. But we have, you're going to see, there is a poster here presented by Dr. Nicola, and he is very close to have an excellent assay for measuring the transport activity. So when we started working on newborn screening for GAMT deficiency, we knew that guanidinoacetate was very high, and it was very high even in a newborn with GAMT deficiency. So we started with a pilot project, and we looked at about 10,000 blood spots. And again, the method to screen for GAMT deficiency can be integrated very easily in the routine newborn screening. It doesn't require an additional test, it doesn't require a different methodology, it just requires to add an internal standard to the mix of the internal standards that are used already in the routine screening. So these are the original results. We started working on this in 2012, 2013, so it's been a while. And you can see that the red circle represents values from patients we confirmed GAMT deficiency, blood spot of babies that, who were diagnosed with GAMT deficiency. The open circle represents the mean and the standard deviation of the control. So there is a very good discrimination, no overlap between GAMT values of guanidinoacetate in patients with GAMT deficiency compared to the unaffected control. If we looked at creatine, creatine was actually overlapping with the normal in the first week of life, and then with time it would decrease and go below the value for the normal, the unaffected control, probably reflecting some contribution still from the mom creatine. So we knew, again, to remind you the newborn screening definition, we need to have the possibility of identify these conditions early. Well, we have a marker now that's available and it's present and can be detected in the neonatal period. In addition, to increase the specificity and to decrease the false positive, the possible false positive, we could look at the ratio also guanidinoacetate creatine, which of course in patients with GAMT deficiency is going to be much higher. And again, the black circle here represents the control, and the red circle GAMT patient. So we still had a few, let's call it false positive in this first study, but we were able to then evaluate other ratio and with other markers to decrease that false, the number of false positive. So we implemented, Utah implemented the statewide screening in 2015, June 1st, 2015. So we were definitely early adopter, Utah was. And we were, our lab was doing the screening. In 2019, the newborn screening was moved back within the Department of Health, but they continued the statewide screening for GAMT deficiency. They've always been very supportive of this screening from the very beginning. New York State started screening for GAMT deficiency in the fall of 2018. And then finally, the end of 2020 and beginning of 2021, Utah and New York identified the 2 infants with GAMT deficiency through newborn screening. Why did I say finally? Because this was the only thing that was missing to proceed to the evaluation of GAMT deficiency for inclusion in the recommended uniform screening panel. And this, again, one thing that I want, this is a message for all the newborn screeners in the audience. We worked, we ran a different method for the screening. Okay, in Utah, we were using a derivatized method. The Department of Health uses a non-derivatized method. New York, I believe, uses a derivatized method. It works. It doesn't matter how you do it. This screening works. And the false positive rate for Utah, considering all the years that we have been doing it, it's really pretty low. I don't think you can get any lower than that. Okay? So then what you need, once you identify them, you need to do a good confirmatory test, and the measurement of guanidino acetate in plasma is necessary to confirm or exclude the diagnosis. Urine by itself is not sufficient. As you can see, the urine value for the Utah patient was within the normal range. So if one does only urine, the risk is there is a good probability, probably I would say 50-50, probability that the results are going to be within the normal range and you're going to miss the diagnosis. So you can do urine, but you need to do plasma as well, and plasma is the most informative. Okay, so this was what we needed, and finally GAMT deficiency is included in the recommended uniform screening panel since January 4, 2023. This is the letter from the Secretary of Health and Human Services with the approval. So now we have two more conditions. So what about agar deficiency? We have seen that guanidino acetate is very low, but now newborn screening is very, very good at identifying markers that are elevated. When we are looking at markers that can be low, it's not as good, okay? So we can look at low guanidino acetate, but there is going to be some overlap with the unaffected control. We don't have any data. The red dashed lines represent the range of guanidino acetate that has been measured in blood spots of only one patient over 1 month of life. So there were 3 or 4 measurements done, and so it's low, it's lower, but there is some overlap. So we definitely need more data and possibly an additional marker or a second-tier test for to identify better this patient. Now let's talk about creatine transporter deficiency. This is the probably last crusade for me. There are not yet reliable markers in the red blood spot for CTD. The researchers in Canada, where they use urine for newborn screening, they have demonstrated the feasibility of identifying a patient with CTD using filter paper. However, we don't have any values in babies. So they have looked at 2 years old and the ratio was elevated. So they only demonstrated that if it's collected on filter paper, the urine, it can give you the same results that the liquid sample. Now, recently, last month, there was a paper that came out and basically said the plasma creatine ratio may be informative in the diagnosis of CTD. This was published from the group at Mayo, led by Dr. Hall. And actually, where they have looked at the creatinine value in this patient, and they found that the creatinine was especially low in patients with creatine transporter deficiency. We have been working in evaluating feasibility of newborn screening for CTD for probably 2 or 3 years now. And I'm going to show you some results. Again, very preliminary results. Don't get too excited, but because we need still to demonstrate with more data. We had 5 residual dry blood spots from patients with confirmed CTD. Storage condition of this blood spot varied. Some of them were stored at -20 degrees, some refrigerated, and some are room temperature. I'm still trying to clarify which one is which, but the reason why the storage is important is because, especially for creatine, you might see some changes that are due to the storage, and if it's not stored properly. In our studies, when we did the GAMT, the screening, the GAMT screening, -20 was pretty good, and we didn't see any problem with the blood spot stored as -20. Then we had unaffected control from values from residual dry blood spot. These were used for the second-tier GAMT second-tier test. And the reason why we used this is because we had all 3 markers available: creatine, creatinine, and guanidino acetate. So we looked at these data, 700 of them, and this is what we saw. So the red boxes represent the values from the blood spot from patients with creatine transporter deficiency, and the green boxes are the unaffected control. So you can see that we have observed, again, a low creatinine, significantly low creatinine, like what Dr. Hall's manuscript says found in plasma in this blood spot. But differently from their observation, the creatine was low, and the ratio creatine-creatinine was low as well. So again, could the low creatine be a side effect of the storage? That's something that we need to figure out. I think that there might, but it's not. It shouldn't be so significant, the effect, but it's something that needs to be confirmed. If we look again, and we try to look at creatinine and creatine, and we try to separate this using a cutoff for creatine that's much higher than what we have seen in the highest blood spot from patients with creatine transporter deficiency. You can see that there is a clustering of the patient in the lower quadrant. So I think that these results are encouraging, but again, let's not get too carried away and too excited. We need, there is still the possibility of some false positive, and therefore additional marker or second-tier tests are going to be necessary for this as well. So we have seen that creatine deficiency syndrome include defects of synthesis and transport of creatine. Newborn screening is very effective for GAMT deficiency. You have heard just the story of the tribe family. And could be effective for agate deficiency as well, but we don't have enough data. And although there is not an effective therapy yet for CTD, we are optimistic that we can get at least to a good newborn screening and an early identification for this patient. And with this, I want to acknowledge everybody who has been a part of this journey from the very beginning. First, the patients and families and the Association for Creatine Deficiency, my lab at ARUP, the Metabolic Clinic and the Division of Medical Genetics at the University of Utah, and the Utah Department of Health Newborn Screening Lab and Follow-Up Program. Thank you.
Any questions for Marzia?
For the the decreased creatine in the dry blood spots, where we're wondering, is this an artifact of not being stored at a very cold temperature? Could you possibly duplicate the not stored at a low temperature with controls and say, looks like really this is low, or, oh, it is an artifact? Like, are you going to do that?
Yeah. This definitely there are ways that we can mimic. Even though sometimes when you mimic these things, they don't behave exactly like the real, but we can definitely mimic the storage condition.
Hi, thank you. So I have a son with CTD. He's 4.5. Would it be beneficial for you to take samples from maybe him, regardless of his age, to use as a control, if that might be more helpful?
Yes. I think I think it would be very helpful, and we are completing an IRB protocol that will allow us to take this sample and also some residual blood spot as well. Although sometimes the newborn blood spot, again, is different because of, there are no other confounding factors such as diet or so, but definitely would be very helpful to see even why is it low in the blood spot. Is it because of the blood spot and because of, I don't know, when you extract it, is trapped somehow, or it would give a lot of important information, definitely. So stay tuned.
Hello, thank you. It was a really informative talk. I have a question about the NMR spectra that you showed initially with the control that had a creatine peak. There were a couple of other differences in the spectra, and I was curious to know if you had looked into what other possible markers are deficient in the CTD and if that could lead you in an interesting way.
This is a question that Dr. Longo can answer because he's more, he looks at this spectrum more than me. Dr. Longo. Or
Sorry.
I can address that. I'm talking after her. Give me 5 minutes, okay?
I'm just wondering if the question is regarding the optimization conditions for the dry blood spots. Can you use creatine transporter deficient mice and take the blood spots and then use different conditions like freezing, thawing, multiple freezing, thawing, and that will give you an answer?
Yes, I can. Do you have them?
Yes.
Please send them to me.
How many?
We'll talk later.
I have a question about the slide you showed with the GAMT patient and the different spikes in the MRS. So the choline spike in the brain for a GAMT patient, as far as like just a normal patient, do you see any reduction at all, even if it's still within the normal range? Do you see a decreased choline spike ever?
Again, he will talk about that.
We'll talk about it? Okay.
Yeah.
And I have some helpful maybe insights into before my son was diagnosed. So he was diagnosed at 13 months old, but before that I took him to see a neurodevelopmental pediatrician. And before we ever started treating him for GAMT, we started him on phosphatidylcholine. And within a few hours, we saw a dramatic change in his movements. So he went from like not being able to hold anything to being able to hold a ball for a few seconds. So just a dramatic difference in treating him with the choline. But when he was diagnosed at 13 months, they said, take him off of that because we want to start him on the treatment that we know that works. And now that he's 16 years old, I've thought about trying to go back and adding the choline supplement to see does it help at all with the current treatment.
Do you want to address that? Or later? Yeah, okay.
Thank you for the wonderful presentation. I was just curious to know that did you observe any kind of differences between the derivatized method what you followed and the non-derivatized method?
So we looked at the data at the average of the guanidino acetate and creatine. Again, the one that we obtained when we were doing the screening in our lab, and the Utah Department of Health that is doing the non-derivatized, and we didn't see really any substantial difference. So probably creatine was a little bit higher in the non-derivatized, but nothing really significant that would cause, a problem in the detection.
So the method what you use is along with your routine amino acid acyl carnitine, you are spiking with the standards for the.
Yeah.
Okay.
That's what we did. We used, again, we didn't use a kit. We used, our method was a laboratory developed test. So we added the internal standard together with, for creatine and guanidino acetate, together with the isocarnitine, succinyl acetone, and amino acids.
So that's your lab developed test, what you suggest.
Mm-hmm.
So I know this would be a very weird question to ask at this point, but I was curious, what about the future of all this tests, like where you see that it is a lab developed test and you are thinking, or there are so many changes which is happening, which is literally pushing most of the screening labs and all the diagnostic labs that where we are heading, because are we really going to meet what you call the FDA guidelines, or what we, like, because we are, we came from like the University of Iowa, and we are the state which screened for 4 different states, including Iowa, North Dakota, South Dakota, and Alaska. Mm-hmm. So what we develop is our lab-developed test for amino acids and acyl carnitine, and we want to initiate the technology for GAMT or screening for GAMT, but we are still in a shaky platform that because there are so many things which comes up, like we don't want to lose the kind of recovery we get from the derivatized method, and at the same time, we are a little bit in a dicey. So that's what I was wondering, like, so what will be the future you are assuming? Will that be impacted, or it is considered as a grandfather test? So,
well, when it comes to clinical test, whether a screening or diagnostic test, you know that if you modify even the test, that is going to have to go through a fully complete validation, whether it's an FDA following an FDA bioanalytical guidance or not. So clearly, the FDA ruling doesn't help, but yes.
Sorry, one more. This will be the last question for this talk.
I guess I just have a question regarding the mass transitions you guys used for the internal standards. Are you going with the C13 or a deuterated type of, I guess, standard for guac or creatine?
You want to know which specific transition?
Not necessarily the mass transition, but the kind of, what kind of,
whether it's a
C13 or is that like, like...
It's a C13.
And have you tried the deuterated to see if there's any more stability, like anything that would be in favor of one or the other?
It's been many years ago. I think we have tried we have tried the deuterated as well, but we can talk about that later.
Okay.
Yeah.
So, thank you.
Thank you so much, Marzia.